Well, SCARF, also called the Schizophrenia Research Foundation, is one of the oldest mental health NGOs in the country. It's also a very reputed organization both nationally and internationally. The main founder is Dr. Sharda Menon, who is the first woman psychiatrist in the country and who has been awarded with Padma Bhushan and many other awards. And it was her desire that we started a center which focused on rehabilitation of those people suffering from severe mental disorders. And we also thought that it was appropriate to conduct research into mental health because we know very little about what is happening in our own country, in our own city. Therefore, we founded SCARF in 1984, and a group of mental health professionals, philanthropists, we all got together and started it in a very small way. But now, as I said, we are 32 years old. We are the collaborating center of the World Health Organization for Mental Health Research and Training.
One of the areas that Junior Doctors Forum has been interested is using technology to help doctors serve society better. And in that area particularly, you have a great deal of experience in telemedicine for the past 10 years, where you have been able to provide psychiatric services to rural areas and smaller towns. Could you tell us your experience in this regard?
Our first foray into telepsychiatry happened after tsunami. As you know, people in Nagapattinam and Kadalur were suffering a lot. And there were a lot of mental health issues because people had died and children had lost their parents. At that point in time, the Oxfam and the Deutsche Bank approached us and said, why don't you set up a telepsychiatry service so that you can provide counseling to people in distress in Nagapattinam. There aren't many qualified psychologists or social workers in Nagapattinam, and therefore we were really we felt that we would contribute in a big way to this. And that's how we actually started telepsychiatry. But along the way we found that people soon got better, and all we were doing was catering to a group of very severely mentally ill. So it struck us that maybe this is a population that we should focus on during our telepsychiatry experiences. And then what happened was we submitted a proposal to the Tata Trust about 7 years ago to serve the mentally ill in Pudukkottai district. Some of you may know that Pudukkottai district is the most backward district in the entire state of Tamilnadu. Backward because the opportunities for work are very limited. It's a very dry and arid area. And if you look at some of the health indices or even the development indices, those in Pudukkottai are much lower even than the national average. So we selected Pudukkottai, and what we also did was, we did a major innovation. We started mobile telepsychiatry. In the sense, we got hold of a bus and we equipped it with telepsychiatry gadgets. And we also had a pharmacy on the bus. We had a nurse on the bus and a pharmacist on the bus. And of course, we had our community level workers on the ground. So this bus was essentially going from place to place in Pudukkottai, and it was connecting to the psychiatrist who was in Chennai. The same amount of privacy that we have in a consultation room, we were able to create inside the bus. But because we were dealing with the severely mentally ill, initially we had to get all the family members onto the bus because, as you know, persons with schizophrenia or bipolar disorder don't always know that they are sick or don't admit they are sick. So very often we need to take the history from the family, and we especially need the family's help to make sure that they take their medication on time. So that much of privacy was ensured, and both the families and the patients felt extremely comfortable talking to us. Now fortunately, because of TV and iPads and things like that, people are used to gadgets, and therefore it was not too much of a problem. So the bus is not the only place that was delivering the treatment. We also had two what we call fixed line centers. That is basically rooms in various parts of the district where there was equipment which was required to connect to the psychiatrist who was in Chennai. On the whole, during the 4 or 5 years we saw patients, we have now registered about 2,500 patients with serious mental illness. This is not taking into account the depression and anxiety and childhood problems and so on. We have been following them up. Some of course have dropped out, and we are now rigorously trying to integrate them into the state-run centers wherever they are available. Apart from that, we are also doing a lot of rehabilitation. We are providing psychosocial measures of support to the family, and as I said, jobs are very, very important, and we are trying to get them get the improved patients some jobs. So a lot actually can be achieved through telepsychiatry, because we are able to reach out to a larger number of patients. And there is the question of the doctor traveling all the way, the doctor having to spend a couple of days here, go to remote and rural areas. All that does not arise. And what is really remarkable about this is we are able to garner the support of the local community in a big way, because they see the bus moving, they see the patients improving, and the local community really comes forward to help us in every possible manner.
Who is a ground worker in identifying and then getting this, organizing the consultations? Is it the local community health worker who's involved, or is it your person from your organization?
No, we recruit people. 95% of them are women, say in their 20s and 30s, who have had some basic education, but who basically have the time to spare, and more than that, the empathy to understand what the problem is. We give them training initially, and then we follow it up with reinforcer sessions. They're extremely committed and extremely good. They are the ones who detect persons with disorders, bring them either to the bus or to other clinics, and then they follow up with families, they follow up with patients, they make sure medication is taken, and in fact, the whole success of the program really depends on them, how good they are, and the kind of relationship they are able to have with the family and the patient. We have developed modules in Tamil, which we hand over a copy to them, but we have a regular 3-day session for them, which is done at SCAF in the city. And then they are sent out to the field, and of course they have supervisors who are trained social workers. So they report to them, and if they have doubts, they clarify. And they also engage in a lot of public awareness and education. In fact, what we have done is we have fitted the rear end of the bus with a television. And in the evenings, the bus goes and parks itself in, say, Mofussil bus stops, where people are just hanging out, doing nothing, waiting for the bus. And then we show some short films in Tamil on mental health, various aspects of mental health, and we find that this is a good way of improving awareness in the local rural population. The dropout rate is about 30 to 40%, but that is what you will expect in any health.
It's not just...
no, it has nothing to do with the bus or with the telepsychiatry or anything.
So the dropout rate is...
People will drop out because they improve, people will drop out because they are too far away from the treatment facility. And I'm happy to say that in Madurai now they have a bus, and people from Sikkim and northeast regions, they have come and spent a week with us, and they have in fact sent proposals to their government that they should do telepsychiatry. So it is a highly replicable model and quite cost effective, because initially we had a set of equipments which we had to use, but what we found later on that was not really required. With a good connection of a mobile operator, any mobile service operator, that it's, and a good television screen, both in Chennai and in the peripheral areas, it is eminently possible to deliver good care service. Only one bus now, and the coverage is, see, we are catering to a 500,000 population. But the prevalence of schizophrenia is about 0.5 to 1% of the population. So that's why we landed up with close to 2,000, 2,500 patients. And the coverage is very good because it's largely the community level workers who spread the word around, number one. But what really works is people seeing that a person has improved.
Correct.
That is really the best way to get more and more people into your treatment net. Because they see a man who was extremely violent or agitated, but now he is able to go to work in the 100-day scheme and getting some money.
Yes.
So then they are convinced that they need to come to treatment, because as you know, in rural areas, many of them go for magical religious kinds of treatment. They go to temples or dargahs or churches. Working very closely with the government in Pudukkottai, the district collector is very interested. But I do not know how far they will actually replicate this model. Although, as I said, it's a highly cost-effective, replicable model. So we have a pharmacy on the bus and we have electronic records. So when the doctor prescribes, the nurse there looks at the prescription and she hands over the medicines to the patients. The medication is totally free and so is a consultation. So that way compliance with medication will be better because they are not spending for the medicines, and we are able to give very good quality, high quality medication, and everything is standardized according to we have an SOP as to what should be done under what circumstance. Request for Skype. We do a lot of Skype consultations. And of course phone calls to monitor and to follow up. But very often we have to actually do home visits, because sometimes the patients don't want to come to the center, or they're not able to come to the center. Then we do a lot of home visits and we actually look at the patients. And this is especially with elderly. The older the person gets, what we call comorbidity becomes very, very important. So we largely, we have a network of primary care physicians, and if we have a doubt that there could be an underlying physical disorder, either causing this problem or coexisting with the problem, then we refer them to either the government hospital or the PHC or to this network of primary care physicians that we have. We ask for investigation, and again when they come we review the whole many times we've had epilepsy with psychiatric disorders, metabolic conditions with psychiatric disorders. We definitely have that in mind, and we are very careful, as you said, to think about them and to eliminate them. Looking at app-based treatments, app-based detections, especially among schools and colleges, where we know that people are developing apps for depression, anxiety, stress, burnout, things like that. And it is our desire in the next 2-3 years, in fact we have an ongoing program which we will launch next year, where we are going to ask college students to try these apps and report to us if there's a problem, or report to anybody.